Hello, hello everyone. Okay, we're going to wait for Kim to come online. She will be the one who is hosting. Let's wait for Kim to join first. Today, as you know, if you are following us, we actually invited Dr. Suresh Nair to give us some of his experience, to share with us his experience with difficult fertility issues and recurrent IVF failure. So please give us a while. I'm trying to get Kim to come in. Okay, hold on. Okay, okay, yes. Oh, yay, great. Okay, hi.
Hello,
Okay.
ladies.
Okay, Kim, you can start the hosting.
Okay. Hi, ladies. Thanks for joining us today. So, as Sue Ann mentioned, we are very excited to have Dr. Suresh Nair from Seed of Life joining us today. Okay, before we invite him in, we would like to just let everyone know that our talk doesn't constitute medical advice. Everyone's situation is unique, so please do check with your own doctors before doing any things suggested. Okay, so without further ado, let's invite Dr. Nair in. Oh, so just to share that Suan will be helping us today because Dr. Nair would like to join, share some slides. So that's why Suan is joining us today. Hi, Dr. Nair.
Hi, Kim. Thank you for organizing this.
No
we
problem.
hope to help as many couples as we can. And Suan, thank you very much as well for the lovely introduction. How are you guys doing?
Thank you so much. We are so excited to have you here today. So without much further ado, would you like to start by giving us a quick introduction of who you are and what you do?
Yes. I work at the Mount Elizabeth Novena Hospital. I used to be in Mount Elizabeth Hospital in Orchard as well. And my forte is fertility and also reproductive surgery, but I also deliver babies. And I used to be the past medical director of the Mount Elizabeth Fertility Center some years ago, and then the Pacific Fertility Institute, and now the Advanced Center for Reproductive Medicine. And I'm here in the hope of bringing happiness to those of us are trying to have babies, which is a wonderful thing.
Absolutely.
And I just want to say, as we go along to the slides, we can have the next slide, that, it's a given. We all know that the age-specific fertility rates or our total fertility rates, they're declining all around the world, particularly in our country. Our government is trying its level best to help us in every way it can to get our fertility rates up, and I will make some comments about that later on. But suffice to say, for a country to replace its generations, you need a fertility rate of 2.1, and we are at 1.1, and we are trying to make an effort to encourage men and women to get together to make babies. But, it's a stressful environment we live in. That's a lot of demands made. And, Kim and everyone, it's not, you see, a lot of times people imagine that when we talk about a seminar or a chat about fertility, it's a woman's problem. Not at all.
Yes.
The sperm counts throughout the world has been declining to more than half what it was more than 40 years ago. And this is particularly because of all the toxins we have. So men have contributed to the lack of conceiving just as much. Move on to the next slide. Let's see. I just want to move on. That's the calculation. Let's move on to the next slide. Just let me go on with that. Let's carry on. Okay, can we move on to the next one? Yeah, perfect. You see, I just want to give you a bit of background. We as human beings, not very efficient at getting pregnant. Per month, the chance of us conceiving is only 15 to 20%. So don't be too distressed if you're gotten married and you're taking about a couple of months. Give yourself an opportunity, especially if you're younger than 35. We tend to give at least a year. But if you already know that your periods are irregular, or let's say you've had an appendicectomy done before it perforated, or some other things, you had a cyst removed, or your husband has had an injury in the testes, or that had an operation when he was a young boy for hernia operations and things like that, maybe it might be a good idea to go and see a doctor earlier rather than later. But if all things being all right, it is reasonable to try for a year or so. But if you're more than 35, and I'm talking about the wife's age, then you might try for 6 months, beyond which it's always better to get things going. But in my opinion, I think every couple that gets married should do what's known as pre-pregnancy preparation, that all your vaccines are taken care of. Go for a simple breast ultrasound, go simple health check, make sure I don't have already a cyst, because sometimes some of my couples come in pregnant with a big, huge cyst, and that might compromise your pregnancy. So it's a good thing to do, pre-pregnancy preparations. So as I mentioned earlier, sperm counts have been declining. 1 in 20 young men actually have significant problems with the sperms. Now, how much contribution from men, how much contribution from women? It's about equal, maybe 30, 30, 30, 10. That's what we say. 30 men, 30 women, 30 together, and 10%, we don't know why. We start investigating and maybe we know. Let's move on to the next slide. I just want to show you this pie chart. It may not be so clear, but let me say overall, in women, we start thinking about the ovary, maybe ovulation problems, tubes. The tubes are a significant source of cause of problems as well. And then the very rare, unusual things like congenital malformations, and there's a condition called endometriosis that is somewhat not often addressed sufficiently, and we keep on trying and trying. And one of the potent reasons, and today's topic, why doctor, am I not getting pregnant after trying so many times, is this condition called endometriosis adenomyosis, which is embedded in the uterus and around the uterus. It's, for want of a better way of describing it, like rust patches in the exterior that doesn't allow good functioning. It produces toxic substances that's toxic to the sperm and the eggs and the embryo as well. Or due to some infection, the womb lining is unhealthy, or the tubes are swollen. And we know swollen tubes, it's called hydrosalpinges, may not be quite readily seen on a routine scan, but it appears sometimes, it doesn't appear sometimes. If something is very obvious, of course, the doctor would have attended to it. But sometimes there are a lot of subtle things that are very hard to determine. And this might be a prevailing thing that keeps on affecting us cycle over cycle. And therefore, we'll have to investigate that. Let's go to the next slide, a quick one. This is a very important slide I just want to show you all. You see, we reach our peak fertility 20 to 25, but it begins to decline by the age of 25. Now, don't get alarmed that, oh gosh, at 25, things are going to go wrong. It is a gentle, subtle decline, 4 to 8%, but once you hit the 30 to 35 age group, 15 to 19, yes, it's coming down a little bit more faster, but it takes a exponential dip from age of 35 to 40, 26 to 46%. And that's when, honestly, all of us, a lot of demands are made on young women nowadays. I mean, you're expected to be very good in scholastically. Then you go to the workplace, you're supposed to perform, and you come back home, you're supposed, if you're married, you're supposed to ensure the husband has the food, Everyone has the food, and if you've already got a child, you've got to be a wonderful mom, good to your mother-in-law, good to your mom, and then workplace, you're supposed to perform huge amounts of demands. You know, there's only 24 hours in a day, so things get deferred, and the having of a baby, we think so much about, I want everything for my child, and we keep in the quest of trying to get things, we forget that time passes us by very quickly. Before you know it, it's 2 years hence, and so on and so forth. So, I mean, these are the things that I want to, you know, put across as to one of the most potent reasons why, when we start too late, even technology finds it difficult to achieve success quickly. Next, let's go on to the next one. A very quick one. This is also a very interesting slide. Good information to know. You know, when a girl is in a mother's womb, she has about 7 million early forming eggs. And by the time she is born, it drops to 2 million. That's reasonable, that's all right. But when she goes into puberty, she's got about 500,000, which is 500,000. And she releases throughout her reproductive career about 500 eggs, and the rest actually degenerate and they go atresia, 1,000 eggs a month. Now, don't be alarmed at the number. That's the norm. We still can manage to get babies and so on and so forth. But some of us have a lower starting point. Some of us have a good number of eggs, and for some reason, something has gone on in our past, that maybe a bad flu or bad infection or exposure in some countries where the water supply is polluted and things like that, you know, high lead levels, high other toxic substances in our environment can impact both men and women in many ways. And by the age of 37, we've got 25,000 eggs, and it declines, and by 40 years, about 1,000 eggs. But the problem is, if I had 1,000 eggs and I got good quality eggs, I don't mind really. I can still manage. But if I have a double whammy, it's really not fair. So it's truly a concern we have as doctors and couples. Now, this is not to say that the men remain in pristine shape all through the years, you know. Yes, in men, the sperms, you have new genetic material every 3 months, but over time, age also affects the sperm quality, the DNA of the sperms. And that's why I make it a special point in checking the DNA of the sperms, because they too contribute to the miscarriages. They too contribute to recurrent implantation failures or recurrent problems of not getting pregnant each IVF cycle. So in a analysis, the doctor would and should emphasize and look into both building blocks, as it were. All right. This is just a slide to show the miscarriage rates. There's a question I will be addressing later as well. Next one. Let's go to look at next one. So this is similar to what I mentioned. As our fertility goes down, our miscarriage rate goes up, both because fertility goes down because fewer eggs and miscarriages because of the quality. So egg quality, egg number. The next slide. So what is the definition? I mean, overall, the doctors have come to a consensus that maybe if you have 3 must be well conducted IVF cycles, not something that you started and then not completed, and you've had, these are fresh cycles, by definition, the fresh cycles, and good quality embryos, and yet we haven't gotten pregnant, then it's time to, in fact, even one unsuccessful cycle is enough for us to really go all out to find out reasons why. Because the abject disappointment and anguish a couple goes through, and I mean, this is not inexpensive treatments. It takes a lot of time for you to go through it, and the high expectations and then the letdown, it's heavy going, to say the least. And those of us who have gone through that know only too well how difficult it is. So that's why I want to try my level best today to see how I can provide as much information as I can to help us along. Now, this is a bit of a crowded slide. I don't think you can see it very clearly.
Could you enlarge them a bit?
Yes, we can enlarge it. Let's go close up and go upwards first. Let's go close up. Okay, let's close a little bit closer. Anyway, I can read it up to you. The anatomic factor, that's the word on your left hand side. You have the word septectomy, myomectomy, a whole lot of medical terms. Basically, it means whenever we are not successful, we have to seriously look. In fact, even before we even try an IVF cycle, before we even put in an embryo, as I mentioned, you have to look into the workings of the womb. Is there anything wrong with my plumbing? Is there anything wrong with my chamber? Is there anything wrong with the passage into which my embryo is going to be put in? Because the last thing I want is when I'm putting my embryo in, I meet up with an obstruction or a polyp that's there that causes bleeding, and that's not going to augur well for success. Absolutely. On the other side is the embryonic factors, which can be genetic. And I would like to spend some time talking to you about pre-implantation genetic testing for chromosomal abnormalities. Is a big area that's responsible for our non-successful cycles. And then, of course, new advances in growing blastocysts. And the question was asked, do I put day 3 embryos or day 5 embryos? I will be talking about that. And some of the new things that are coming, not so much pre-implantation genetic testing. Suppose we don't have that readily available. What surrogate methods do we have? We have something called the embryoscope or the time-lapse videography. What it means is, to draw an analogy, this is how I describe it to my patients. Suppose I've got 2 primary 5 students, and I don't know who is the better of the 2 to put in the primary 6. I will look at his background. If one of them had gone to primary 1 and 2, skipped primary 3, and then fell back onto primary 2, and then jumped into primary 4, he's showing a disordered development, right?
Yes.
Then I will keep an eye on that one. I wouldn't discard the embryo. I think it's still all right to put it in. But if I had to choose, I'd rather choose the one that's gone to primary 1, 2, 3, 4, and 5. Passed all his exams, all her exams, and I'd rather choose that. So, embryoscope, 2 major advances. It is a closed system. You don't have them opening up the incubator all the time and disrupting the environment. So when the sperm and the eggs are ICSI'd and put into one end, the embryologist can see all of your embryos without touching them through a video camera and see them growing, and he can check them many times, and he doesn't have to sit there and watch them. There are about a few hundred pictures that are taken, and you see the evolution of your embryo. And one of the reasons why we have gotten it, and most of the IVF centers in Singapore have it now, is because much as you have a very good embryologist, sometimes it gets exceedingly difficult to say, I haven't worked out on this embryo transfer. I got 6 more embryos to put in. Which one do I choose? I don't want to go through failure after failure. Which of this is coming close to the best of the best? And then this is one way to select it out. Now, remember I say we should not forget the men. The men are responsible. Sperm problems are a major issue, a major issue. You can get into situations like swollen veins that cause heating up of the sperms, damaging the DNA, making them not move as fast, making them misshapen, and so on and so forth. So how do I, the embryologist, like my embryologist, select out? Because you see, if you have only a few good eggs, I have to get the best sperms I can possibly get to fertilize. Otherwise, that nice egg will be totally damaged because I put in a poorer sperm, you see. So there are a few methods. One is to use something called the Pixie. It's like the GPS of whether the sperm has got good GPS, for want of a better way. We put artificial eggshells one side and let it all swim and stick on there, and you show that that is a smart sperm. a smart sperm is physiologically healthy. I pick that up. Then the embryologist has a special magnet. It's called Annexin 5. It's available in most of the IVF centers, where they put it there, and the sperms that are bad, they are a scavenger. You know, they scavenge out all the bad sperms and damaged sperms and all the toxic materials, leaving behind the good ones. And then out of these good ones, they have something called IMSI, where they magnify the sperm so much that they can see all these fragments, the sand. The more broken up the nucleus, the worse it is. So if I'm having a sperm after all of these exams, I mean, gone through the selection process, and then I see it's a nice, pristine, not many particles, then I take that sperm and I inject it, that's called ICSI, into the egg. And that's one of the things, because for many years now, women have had to go through the anguish and the physical and psychological, I dare say, trauma. And you know,
the men have it easy.
He just produces the sperms, and we as practitioners have tried to try our best, because we knew that we've not been able to do justice on the male side, and now we are getting there, you know, to try and select. And sometimes if the sperms are not sufficient, very, very low sperm counts, we go to the testis and kind of suck it out from the cells. That's called TC. And that's well established as well. Moving along, then comes the womb lining. And actually, as I'm going through my slides, I'm also addressing the question of what happens if I don't succeed the first time, the second time. I then look into the womb lining. How can some of us have poorer, thin womb lining, but having a thick, very fluffy womb lining is not good either. So we want a nice sweet spot between 8 to 10 millimeters, maybe 12 millimeters of distance from one side to another. And there's this word used by a lot of practitioners. It's called trilaminar, three-layered lining. And within that, we hope we don't see patches or polyps or things like that. Now, what then can I do to improve the blood circulation? We can use aspirin, so it doesn't clot up, the platelets doesn't stick. We also use sildenafil. Actually, sildenafil is actually Viagra. Although there's a lot of controversy, what I'm saying need not necessarily be agreed upon by all practitioners, but this is my point of view. Sildenafil is something that opens up blood vessels, and that's how it works in erectile dysfunction. But it's used either per rectally or per vaginally to open up the blood vessels of the womb in the hope that we get nourishing, more oxygenation and things like that. And that's why if you have you want to do something about your healthy living styles, a gentle exercise is good, but excessive exercise is not good because it shunts away blood from your reproductive organs to your musculature. So
what would you say is excessive exercise?
Well, if you run like 5 kilometers even a day, if you do, a lot of weights and, cardio, tremendous cardio for many hours in a day, that I would say is excessive. If you do enough, like a brisk walk, even a nice swim, a little bit of a sweat, the heart rate going about 120, max 150, and light weights, but many repetitions rather than huffing and puffing where it extracts a lot of blood supply to muscle building. This is the problem I see in my very fit individuals. They come to me and say, "Doc, I'm very fit. Why do you say my sperm counts are poor?" and so on and so forth. It's the heat buildup. And an excessively high protein diet is not good either. A nice balanced diet, some vegetables or multicolored vegetables, a bit of carbo, some meat, and the portions that you have is just that which fits the palm of your hand per meal. That's reasonable, and if you enjoy a nice cup of coffee, in the morning, by all means. It's already stressful enough to go through all of this. I am not so draconian in my advice for my couples, enjoy your coffee, you know.
Okay.
That's fine, you know.
That's
So
nice.
moving on, how do I make my circulation better?
Yeah.
We also give higher doses of estrogens. Estrogens build up my lining. Sometimes the oral version doesn't go sufficiently, it doesn't get broken down in the liver appropriately. So I use patches of estrogens that goes through the skin directly to the womb. And then we also use sometimes low molecular weight heparins, we call it, Clexane, to dilute the blood, especially in those of us who have thrombophilias, clotting problems. So
Yes.
whenever I find that my couples don't conceive fast enough, then the next phase is I start looking into all of this fine-tuned tests, you see. And a lot of couples that come to me have already gone through the phases. They're in Indonesia, Vietnam, Malaysia, elsewhere. They've gone through multiple cycles. And then we have to plow through all of their data. It's important because you want to know what they had gone through, what worked, what didn't work. And then you have to do these further tests. And I often involve multidisciplinary doctors. I have a colleague who is a reproductive immunologist, looking at the immunology and through the eyes of the fertility expert as well, to see whether or not, and what I'm saying need not necessarily be acceptable to all of the practitioners, I must say. There's a certain degree of controversy as to whether we should use, you know, intralipid, whether we should use other things as well. For example, prednisolone or IVIG, which is certain things to tame our body not to produce antibodies against us. And sometimes, lo and behold, whenever we are testing, we suddenly find out we have something called antiphospholipid syndrome, and you have no symptoms, you know, aside from non-implantation. You may not even reach the point where you miscarry. And so there are specific treatments for that. So better we find out earlier rather than later. But that's not to say that everyone gets this testing done. It's very expensive, and majority of us don't have it, thankfully. And so these are the things we will do. And to improve our pregnancy rate, sometimes we, after selecting out a good embryo, and the embryologist that we have is most important. No IVF program, the nucleus of the IVF program, honestly, is I have to give my embryologist good building blocks. So good treatments. For example, when we use these injectables, there's pure FSH, but there's also something called FSH-LH combination, like the yin and the yang, you know.
Okay.
When we are older, we need both of this. And so there are certain medications that we can use. And there was a question asked, how about the difference between what we do and what my colleagues in the public sector do?
Public sectors do, yes.
I suppose they can't help because they have to have high throughput, but we can individualize treatment. We are a little bit more nimble. We are hands-on in everything that we do. All the procedures are done. We sit down and discuss the pros and cons, and we know we have greater liberty to tweak our treatments and protocols cycle after cycle, particularly if it doesn't work out, you see. Yes. So that's one of the reasons why I like to do things in my own practice, so that I can, you know, individualize treatments for my couples.
Personalize, yeah.
So a quick word about womb scratching or endometrial scratching. I see that question over there. I think this is an area of controversy, but the assumption is if you create a bit of disturbance, inflammation occurs, and ironically, the womb has to have the inflammatory response to accept the fetus, and after that, there must be a switch to turn it off. So we found that some of the people in which we did some, scratching, and this can also take the approach of a hysteroscopy. When we put a scope in to clean, we can do that also. And let me go on to very quickly about the next video I'm going to show you.
Okay.
Can we go to the quick? This is something we are doing to clear out the fibroid. We are sort of melting it away.
So the yellow part is the fibroid?
Yes, the yellow part is the fibroid. That probe is something that burns out the fibroid. And this girl had been having failed cycles. And we realized it's so subtle, we couldn't really see it until we did the scope. And we managed to sort of melt it away. And then after giving her hormones where the new skin grew, she conceived finally. And this is a case where there's a polyp we removed. And next to it is a big fibroid, and we can then sort of shave off. You see this big fibroid? Actually, when you pump up the water inside, you don't see it. When you do a scan, we couldn't really tell whether it was inside the womb or outside. Only when we did the scope, we realized it. And then we got it out, and then this girl took a few months to grow a new lining, and thankfully she got pregnant after that. Can we go to the next? Now, this is, I am a strong proponent of robotic surgery. I think some of my colleagues just do the surgery laparoscopically. That's fine as well. But I find that in order, you see, we have only got one chance at the pelvis. Because if you don't do the surgery right and you cause scarring, go to the next video, please. If it's still scarring, that will also be detrimental. Here, I'm using a very fine instrument. This is a lady who's got endometriosis. That white and brown thing there is endometriosis. We are penciling out very precisely all of this endometriosis. And after this, actually, ironically, I created embryos first. This patient actually got pregnant spontaneously after this, even before I could put the embryos in. So sometimes when you take away the noxious stimulus, this happens. And someone asked me about the adenomyosis. Adenomyosis is next video. The adenomyosis that adenomyosis is best treated with medication. I find I really don't like cutting into the uterus because I want to preserve my womb as much as I can and do the surgery when absolutely necessary. This is a girl who had a big endometriotic cyst. But what I did was to create the embryo first, because every time you do a cyst operation, you can actually diminish the egg reserve. So you have to be very precise and tender to the wall of the ovary and do it very gently. Sorry, it's a little bit bloody, but this is to show you that we are very, we spot well. We don't sort of cauterize, as it were, the entire ovary, and we nicely reconstruct it back again to what nature intended to be. And this ovary began to function again, and we got a good pregnancy rate. And so this kind of surgery, some doctors like to do it before the IVF cycle, some doctors don't do it. I only do it when it's extremely large. The smaller ones, best left untouched. Shouldn't damage the ovary if we can help it. Okay. Next one. And so, so going on to the next slide, if you have the next slide, just to show you a quick word about, someone is asking me, if the AMH is undetectable, will you be, should I be excluded from the IVF program? Absolutely not. I will still try my best to use maybe a more gentle stimulation because it's cost containment. Whether I use medications like clomiphene or whether I use medications, injectables, I might get the same response. So why use expensive medications? And even if I can get one egg, I have actually gone in and done what's known as flushing of the follicle so that I can get, some doctors believe in doing that, some doctors don't. I do because I feel I want to persevere until we get that egg. Hopefully we do. And there's another question. As I'm looking, I'll just quickly answer this question. Azoospermia. Azoospermia just means that you could not get sperms through the ejaculation method. But that doesn't mean there's no sperms. You see, sometimes there's a blockage. We can go to the testis and get it. But if there is what's known as primary testicular failure, Then in Singapore, we are allowed to import donor sperms, and the government encourages that if you really don't have sperms, or if a husband has a brother and if they are all comfortable with this type of assistance, then we do allow that as well. I just want to quickly run through a few words in that slide. I feel this is an important slide. For those of us, although social egg freezing is not allowed in Singapore, this is a good slide for you to just remember that should you consider doing that, the number of, if you had 20 eggs, what is your chance of having 1 birth, 2 births, and 3 births? So this is just information for everyone to just recognize, okay? This is just window of implantation, but let's say, I'm interested in that question about dual stimulation. May I just expound on that, Kim?
Yeah, sure, no problem.
Dual stimulation is honestly something I do a lot of. Because what does dual stim means? In a regular cycle, when you start on day 2 of your cycle, you stimulate, right? And you take out the eggs. But actually, we realize the human ovary is so resilient that in 2 weeks, that ovary, she is actually producing smaller little follicles ready to go, you know. Now, if you use the normal HCG as a trigger, you spoil those tiny ones. But if you use something called, and you might want to jot this down, it's called agonist trigger, AGONIST trigger, read about it. That allows your small antral follicles, the second wave as it were, to be undisturbed. And after 5 days of allowing the blood clots after you've taken out the eggs to settle, you can stimulate again. And apparently it's been shown that in the second wave of stimulation, you might actually get better quality eggs and maybe more. It's called the luteal phase stimulation. That means in the second phase of your cycle stimulation. And this is something I do in quite a number of cases, especially those who haven't got as much eggs, because, you know, over months, if you do one cycle and you rest another cycle and you suddenly find the AMH dropping from 3 to maybe 1 or 0.7 or something like that. So whether we stimulate or not, eggs are flowing by us anyway. So the best thing to do, remember the analogy of the stream of fish flowing by. Nature is one fishing rod. IVF is casting a net and bringing the eggs in. And the more times I cast my net, the higher my successes. So the question is, what are your success rates for dual stim? It's got to do with the number of eggs we get. It's been shown that whether you are 30 years old, 35 years old, 40 years old, the optimal number of eggs to give you high success is 15. Okay, ironically, the funny thing that this study showed is if you go to 20 or 25, somehow the success rate actually decline. But the way we do dual stimulation is I create the eggs, or rather grow the eggs, retrieve the eggs, create the embryo and freeze it. And then we are ready to go another time and freeze it. We stockpile our embryos. And very quickly, I want to just say a few words about day 3 and day 5. For a long time, we were doing day 3 embryos. But these days, for a multitude of reasons, be it the embryoscope or PGTA and high resilience, we rather get, because we know that now we can do, the government has realized that the way modern IVF should be done is multiple small cycles. And so they lifted the restriction now because modern day IVF dictates that it's important to get as many eggs and create as many embryos as you can within the limits. I mean, one of the big limitation factors is, of course, cost, is to get your most resilient AA grade, hopefully, embryos and stockpile. And our techniques of freezing the embryo is so good now, vitrification is called, that the loss rate, if you unfreeze it or warm it, is very low. Nearly 95%, maybe 99% of our embryos survive.
Wow. Okay.
So that way, that's why we have a tendency to stockpile our embryos, create our embryos, then clean up our womb, both externally and internally. Then if there's adenomyosis, shrink it down with medication. Then give estrogens to build up a beautiful lining, then take one of our embryos and put it in and hope, God willing, we are pregnant, you see. So there's another very interesting question. Is there anything to help ladies with endometriosis and retroverted uterus in terms of implantation success? Okay, one misconception I want to clear is whether your uterus is retroverted or antiverted does not matter. But a lot of women who have bad endometriosis may have their womb stuck back on their rectum. So I believe, in my opinion, and there's a lot of hard data to prove this, because way back in 1997, the Canadians did a study of 1,927 patients where they subdivided into doing laparoscopy for both. And you know, endometriosis is graded into 4 stages. In one of them, they just looked and did nothing. The others, they looked and did clearance. In those days, we didn't have robotic surgery. Now with robotic surgery, we are a lot better at it. And they found whether it is normal conception or whether IUI or IVF, consistently those who had the endometriosis cleared did always better. And so these days, we cannot repeat the study because it's unethical. So no one would do laparoscopy just to look and see and do nothing. We have to do therapeutic laparoscopy. So to answer the question, yes, I feel that endometriosis is a significant issue, but because it is an invasive intervention where it needs laparoscopy and all that, sometimes, you know, we discuss with the couple, should we just go ahead and put one embryo? If I get pregnant, that's all we need. We hope we can, but if we don't, and those of us who recurrently don't succeed, then you got to go and discuss with your doctor. And if your doctor is there are 2 types of fertility doctors. There are those who do the medical type of IVF, and those who are reproductive surgeons as well as IVF doctors. Or sometimes they farm out, so to speak, the fertility surgery, or they do it with a laparoscopic surgeon. But laparoscopic surgeons sometimes, you know, I mean, I don't want to say anything controversial, but, you know, one has to be very respectful of the tissues you handle. And that is why sometimes I sit down for many hours to do the surgery very carefully. And that's why I'm a strong proponent of robotic surgery, because I feel I can do my best work. And I've been doing that since 2006, and I've made comparisons as a single surgeon doing similar cases. My robotic surgery success rates are a lot better than the laparoscopy surgery. So to answer the question about endometriosis, yes, that's something you should start thinking about. And one more thing I want to highlight, it does not mean that if you have menstrual pain and therefore you have endometriosis. I have women who have no symptom at all, and when we put a scope in, the whole pelvis is teeming with endometriosis. And that was the reason why she wasn't getting pregnant. There's another question. I keep getting day 6 embryos. Now, day 6 embryos are not too bad. They are reasonable. They take a little bit longer to grow. And therein lies the concept of growing your embryos to a blastocyst. So even if I am a student who is in the normal stream, I need 1 more year to go to PSLE. That doesn't mean I can't be great at being a great student myself. I just take a bit longer. So as long as I get a good quality embryo, I think we should be able to transfer. So don't feel too despondent when you get a day 6. Of course, in an ideal world, we would like to have a 5-day embryo at 5 days, you see. The other question was day 3, again, a day 3 or day 5.
Yes.
A good number of doctors, there was a big debate some years ago, but these days you will find that 90% of our IVF centers are towards blastocyst transfer to get the most resilient and strongest ones. And it's been shown that you have almost a doubling of the pregnancy rates compared to day 3 embryos. And if you want to you're in an environment where you can do pre-implantation genetic testing and all, then you have to have blastocysts. You should not do it in the old technology where you take one of the cells of the day 3. Embryos arresting at day 3, are there any reasons? Yes. Very good question. One of the things we have a look at is, of course, egg quality. It's also got to do with what kind of stimulation that we had used, and also the sperms. The sperms have also a tremendous contributing factor, not only at fertilization, but it carrying on from there. It means that the embryo, the egg can take care of things up to day 3. Then as a teenager going into adulthood, from day 3 onwards, the embryo is on its own. So if the culture conditions are not just right, or if the IVF center is not as good in growing blastocysts, they don't do it on a regular basis, then you might want to ask your doctor, can I do the IVF in a place where they do blastocysts on a regular basis, and maybe they can grow the embryos a lot better. Why the follicles did not rupture, and what can we do to remove the old follicles? Okay, there's such a thing as the luteinized unruptured follicle syndrome, and that's usually in your IUI cycles. And if you find that this is consistently happening, and often it tends to happen in some of the women who have polycystic ovaries or are much older, then one has to seriously think about IVF. And how do we remove the old follicles? We actually can do it medically by giving you a contraceptive pill for a duration, and then that can sequester the follicle. But sometimes I end up with follicles that are just too stubborn to go away. We can actually pop it as if you're doing IVF and suck it away, aspirate it, suck it away, and then we can restart again. Coming back to, okay, how do we identify if we have endometriosis without laparoscopy? Yes, in situations where you see it's very embedded, we call it deeply infiltrating endometriosis, rectovaginal, between the rectum and the vagina, or the lateral pelvic wall, and MRI can show it. But then the MRI forgets or cannot detect the pictures on the wall. The patches you can't detect. So sometimes you get a negative MRI. I do sometimes do an MRI for my patients because I'm planning the surgery. And then they don't, the report comes out, no endometriosis detected. Then when we do the laparoscopy, as I mentioned earlier, the steaming with endometriosis, and these deposits that I remove, I don't just burn them away. Some doctors just burn them away, but it is like the tip of the iceberg, you know. The disease is actually embedded and you've got to get at it. I draw the analogy to my patients. If you have a car that the door panel is rusted, if I scrape away the rust, put putty and give it a coat of paint, 3 months later the rust will come through. If I cut the metal out and then put new metal, then I know it will last, you see. So this is why if you don't look, you shall not see. So in order to really evaluate whether there's endometriosis and get at it, we have to actually do appropriate dissection. We have a multi-physician group, multi-surgeon group. We have colorectal surgeons, we have urologists and the gynecologists who can do both laparoscopic and robotic surgery. We are a reference center, so we receive some of these cases. Some have had operations done, a lot of scarring. Some are brand new, coming in for the first time, either for pain or for fertility. But again, I want to reiterate, pain is not always the accompaniment of endometriosis as well. No? Another question is, why wasn't my embryo implanting, even though I got a good quality embryo? We have to look at, you see, a good quality, a handsome looking embryo need not be a good-hearted embryo, so to speak. you see people and they are not chromosomally normal. Ironically, you may have an average looking embryo, but actually it's chromosomally normal, you see.
So that could happen.
Those are the things we have to look for. So at the end of the day, in instances where a couple has not been successful, I will start looking into, on one hand, immunological things. On the other hand, the embryo, whether there are any chromosomal abnormalities. On the other hand, my womb appearance, my womb environment, and endometriosis. So I will target and investigate and ferret out as a detective would to find out, why haven't I gotten pregnant? What can I do different? And we also tweak on the stimulation. Should we do dual stimulation? Should we use a combination therapy, and so on and so forth. But one prevailing thing I've learned over the years is, it is always important, if a couple were to ask me, is IUI better or IVF better? Clearly IVF is better.
Yes.
We know that. But if one wants to do something naturally, yes, IUI. But then I would suggest to them, you see, time is not on our side. And as a backup plan, because before I do the surgery, some women have big cysts and I wouldn't touch them. I'll do the IVF first, create my blastocysts. Because remember, I said that when we do the cysts, sometimes you render them non-functional. So you can stimulate, get a few blastocysts nicely preserved, then do the corrective surgery. And if the couple wanted to try IUI, they still can, because we got the embryos frozen. Because once I am, let's say, 35, and I got embryos frozen at 35, I have my first child, and now I'm 39, my embryos are of a 35-year-old.
Yes.
And so one of the most powerful things about assisted reproduction like IVF in ICSI is it preserves your fertility infinitum. But that's not to say that you can make your, like some people in the United States get married about early 30s, they make their embryos, it's called social IVF, not allowed here. They make their embryos, or maybe they preserve egg and sperm in case they split up and you don't want to create life, which you do not have babies with. And they have their babies at age 45. But don't forget, the rest of us age. The rest of your body ages, your heart, your lungs, your tissues, and you get all kinds of other diseases. And what about cancers, you see? So still, my main message is, have babies young when you can. And if we are not, not all of us are lucky enough to have the person you can fall in love with, to have a child. That's why I am a strong proponent of allowing women to, the option, men and women, to preserve their age. For women, it's harder to go through, but that's why I gave you that little snippet of the table, so that, should you want to think about it, you can, but this is not allowed in Singapore. In Singapore, the philosophy of the government is, have your babies early, meaning get married, get into the family-oriented culture, so to speak. I think we have to bring that back into the fabric of our society. It's not sufficient to say I have my career. I think both father and mother must be joint partners in the bringing up of children. I'm quite guilty of that. I don't get home often enough, but I think that's very, very important and critical.
But you're helping a lot of people.
That's right. There's a question, would you recommend fresh transfer or frozen?
Yes.
I would tend to do frozen because my philosophy is stockpile your embryos and create your embryos first, because no embryo means there's nothing to talk about.
Yes.
Because many a time in a fresh cycle, and it's been shown by well-conducted studies, the womb lining gets out of synchrony with the growth of the embryo and readiness of the embryo to come in, you see. So we should have mostly frozen embryos, because right now that becomes a reality, because we have very resilient freezing technology. It's called vitrification, where the survival is pretty good. But having said that, sometimes we do what is known as, after the surgery to clean up, we do a fresh frozen embryo. We leapfrog, meaning I got my frozen embryos and I want to create more embryos after surgery. I do another cycle. I keep them. I put my frozen one in and get pregnant, you see. So that's also a possibility. Not all doctors agree with this. Some doctors will feel that get pregnant quickly, just get pregnant, and if you're pregnant, you put in a fresh cycle, a fresh embryo, you're pregnant, end of story. But you see, for me, when I see my patients back again, you know, the impact it makes on a parent when your child goes to school and yearns and asks for a sibling, and then you struggle and struggle and struggle and can't get pregnant. Whereas if I had embryo frozen beforehand, you know, you can have a sibling. So we are talking about not just getting pregnant, but creating a family. Of course, some couples would say, I just want to get pregnant first, doc. But I'll say, we don't know, you know, what if you miscarry? What if at 16 weeks I find it's a Down syndrome baby? What if things don't go right? And the amount of effort came to pick yourself up from that horrible experience, to go at it again. Wow. That's why, as I said last night, women are the strongest sex. I will say that again. Women are the strongest sex. No man can handle this this kind of.
I'm sure you're winning a lot of fans tonight. Yeah. Okay. So let's just run through a few questions. Okay, a few more questions if you have the time. Okay. So is it important to choose the right doctor? And if I don't succeed at a particular clinic, should I change another doctor?
Yeah, that was the first question. Yes. I think if you have reached a point where you need IVF, or you're a little bit older and you've gone to see a doctor, a gynecologist who has given you maybe clomiphene and you're doing it a few cycles, I think after even a 3-month period, if you're not getting a pregnancy, then avail yourself to a fertility expert. Okay. In Singapore, IVF is only done, can be done by those who are accredited and trained to do so, and only in accredited licensed centers. So they are IVF accredited doctors. Now, but that doesn't mean that you can't get fertility treatments from the general gynecologist. Many of the gynecologists can do what's known as superovulation and IUI. Many of my colleagues are excellent at it. They get excellent pregnancy rates. They are very good surgeons as well. But they then realize that maybe, you know, there comes a point in time where an IVF doctor is needed, and we work together to help couples. And then after they've gotten pregnant, I'll have him or her deliver the child. So if you have, what is the scenario with which you want to find yourself in? A doctor who, when you want to do IVF, a doctor who has, of course, good success rates, and also the labs that he works with. Find out which labs is affiliated with, and all the labs in Singapore post the data in their websites, and you can see in some of the other countries they have what's known as league tables, where they are categorized and according to their success rates. But you must also look into not just pure success rates. Look at the age groups, because if they have some of the centers that we use are actually looking after much older patients. They don't not accept them. I don't want to use the word reject, but there are centers who may not
success
want
rates,
to handle, they want to influence the success rate. But we are very accommodating, because everyone we feel deserves a proper assessment and a chance at conceiving a baby. So that's one way to choose. Also, the doctor must have a network of good ancillary specialists, a urologist, a reproductive immunologist, a counselor, a psychologist who will help. I mean, the delivery of bad news, the coping mechanisms, all this is really critical to be able to be available for your patients. And one of the things I like, because I'm in the private sector, is I do everything for my own patient. I do my own scans, I do my own pickups, I do the own embryo transfer. But it's not to say that if you have a team approach that it doesn't work. Your team approach is efficient because there's always going to be a doctor. The doctor is not called away to do other things. Waiting time may not be just as long or so on and so forth. There's pros and cons to it. But, you know, if you have an OB who or rather IVF doctor who can address all of these things for you. We are more nimble. If I don't achieve a pregnancy, I will sit down and reevaluate and find out, okay, should we then consider using this medication? And a doctor who has access to different types of medication rather than heavily protocolized, if there's such a word, would be a better bet for those of us who have been struggling with a number of cycles, compared to someone who, you know, my hands are a little bit tight, I have to follow certain protocols, we might have to tweak it in a different way, and so on and so forth. So to answer the question, should you then jump from doctor to doctor? Absolutely not. Because that same doctor knows you well, and he or she then looks at the past cycle, and it is not only a therapeutic intervention, that means a treatment, but it is also diagnostic. He or she knows that, okay, this didn't work, or when I was doing the embryo transfer, this didn't work out. I will then take that knowledge, assimilate it in my new cycle, and do it. Otherwise, if you go to a brand new doctor, sometimes they cannot accept the results done elsewhere. You might need to repeat some of these tests. And it's a waste of time. You have to rehash all your history again. So I just feel that, you know, a doctor who is trying his or her level best to try to, you know, get the best treatments done for you. You can sit down and talk to him. You say, Doc, I've read about this. What is your opinion about this? Well, I've read about this. What's your opinion about this? Now, if a doctor is in many ways not aligned to what you have read and what you prefer, then of course, then you can say, you know, Doc, maybe I might like to see someone else and I will look into that. Or if a doctor is looking after you and you need a fertility surgeon, then you might want to look for a doctor who can do both the medical part of the IVF and also the surgical part, because a lot of times is the fertility surgery that eventually may, you know, clinch the deal, so to speak, clinch the pregnancy, you see.
Understand.
So that's something, but if a second opinion is required, of course, you know, you must take a second opinion, and, you know, there's a lot of access to the internet, and not everything is internet that is safe for consumption, but you can actually go to the internet, get an opinion from doctors around the world, and check with your doctor. Doc, what do you think about this? Some of us don't believe in any of the treatments like IVIG, intralipid, Clexane, aspirin, prednisolone. Yes, granted, but those of us doctors who I see a lot of my couples who miscarry, don't conceive fast enough. There have been a number of places. I feel beholden to ensure that I've done my level best to try and investigate, even if the technological advances or the data is not so robust. We also, that's why clinical judgment comes in. Per case, to try and, you know, have a good discussion with the couple and see, okay, given that these are the situations, this is the best thing we can do for you.
Understand. Right, perfect. Okay, I think this question we've kind of answered it, but what tips do you have to improve the womb and egg quality?
Okay, so in terms of what the doctor can do and what the couple can do, of course, you know, living a healthy lifestyle. Cigarettes are a definite no-no. I'm not so draconian when it comes to, if you want to have with your meal a glass of wine, I'm quite okay with that. I mean, don't binge drink either. In the weekends, drink a lot, and then after that, go you know, all dry. And I mean, that's fine. I know some of my colleagues are totally antagonistic towards any kind of alcohol.
Yeah.
I think that's fine. A cup of coffee is fine. Take nutritive foods, have your omega, have your range of vitamins. Take methylated folic acid, not the regular folic acid. Methylated folic acid is which goes direct to the fetus, and those of us who have an enzyme defect that doesn't metabolize folic acid sometimes have problems with miscarriages. So in order to circumvent this, because it's more expensive to do testing for everybody, we'd rather use methylated folic acid because it doesn't cost us very much more than the regular folic acid. And then vitamin D is known to be delta is known to be extremely useful for our fertility, our immunity, the bone health, the skin health, a whole lot of things. And that's why during this COVID environment, we use mega doses of vitamin D to combat the virus.
How about supplements like DHEA or,
DHEA has got to do with more improving egg counts in those of us who don't have good egg counts. No, not a good idea to use DHEA if you're otherwise a normal person. But I think it's reasonable to use, the micronutrients in your vitamins and so on and so forth. CoQ enzyme is excellent. It is there's something called the French pine bark, pycnogenol, which is a strong antioxidant. I am a strong believer of antioxidants because our whole environment is full of free radicals. We are exposed to so much in the way of pollutants in the air we breathe, the water we drink, the food we eat, the preservatives that are in our environment, even the clothes that we wear. So we need to combat this by staying in an environment. And if you have a job that exposes you to all kinds of toxic chemicals, I had a girl who worked in the lab and she was exposed to toxic chemicals, then of course we have to change that environment and cleanse our body. I'm a very strong proponent of acupuncture, relaxation. I think, yoga with all the different poses, more to do with not the hot yoga, but more to do with the breathing, the relaxation, and getting your circulation going. Because if you pay attention to good circulation and the simple act of drinking sufficient fluids and water makes us less dehydrated, and therefore there's good circulation to the ovaries, is also a good thing. In our tropical climate, it's very hot, you sweat a lot, it's very humid. You should be attentive to that as well. So those are the things. Now, about the womb, of course, you have to treat your body as if it's with a sanctum of health. You see, you even simple things like avoidance of STDs, multiple partners, or not unprotected intercourse, and so on and so forth. STDs can be very damaging to the female and male reproductive system. It can permanently damage the lining. Keeping in good health, in some countries where tuberculosis is very prevalent, you can damage the uterus permanently. And some of my patients from India, when they come in, or Indonesia, unfortunately, the poor girl has been so badly affected by the TB that you find that that's damaged. There's a quick question: would I recommend Mayo and D-Caro-Inositol? Yes, please go ahead with that. It is a good form of supplementation. It is present in agents like the ones I use is Revosid. Of course, there are many other brands. Yes, it is good for intra-ovarian physiology. So that's a good thing to do as well. Other types of supplements, it's not a supplement, but it's a lifestyle sort of thing. Having good sleep is all important. Without good and restful sleep, even taking melatonin and all that, whilst I'm okay with that, it's always better for all kinds of issues, you know,
Yes.
both your fertility, your mental health, your cardiac health, your overall health, how your body is physiologically functioning well to nurture your baby.
Yeah.
Sleep is a time where your body repairs. So sleep is extremely important. Of course, food, avoiding, you know, foods that with a lot of trans fatty acids, toxics, substances. Once in a while, you want to go for a nice KFC chicken. Yeah, by all means, you know, that's okay. But otherwise, you know, maybe not taking too much in the way of sugars and all, because they're not really good for your body. These are overall general principles of good health.
Understand.
Abusing of, in Singapore at least, that's not as common a problem, but some of the other countries, use of marijuana and cocaine and all that for sure affects your fertility as well. What else do you want to know about?
Okay. How many cycles would you advise your patients to try for IUI or IVF?
Okay, it's all got to do with, again, I know I sound like a broken record, but the female health, female age. If one is a younger couple in their early 30s, let's say, or towards maybe 33, 34, I would recommend well-conducted IUIs. You see, IUI takes a variety of forms.
Yes.
It's either a natural cycle IUI. If you look at it, it doesn't really improve your pregnancy rates very much. If you use clomiphene alone, is 5.6. If you use clomiphene and IUI, a little bit more. But when you use gonadotropins, which is called superovulation and IUI, and as you know, by the time couples come to me, they've already gone through all of this circuit. I sometimes use another medication called letrozole, which is also just as good. Letrozole is good in that it doesn't thin out the lining of as clomiphene does. So I sometimes alternate between one and the other. We find that doing this is good. However, when we want to get to a more a proactive stage, we should consider what is known as superovulation and IUI. Making 1 or 2 or maximum 3 eggs available, not much more than that, because we get multiple pregnancies. And then we concentrate the sperms, and you bypass the cervix and get the sperms into the upper reaches of the womb so that they have high concentration of highly motile, highly active sperms going through both the fallopian tubes to reach the egg in the faster time. And we narrow the window of implantation, you see, getting it as close as possible to the ovulation by triggering. So by controlling this, even if it is one follicle, Kim, we do it better than nature does. Nature has a bit of a haphazard trigger point. Whereas if you conduct, and this is something we borrowed from our IVF knowledge, we do a mini IVF stimulation. That means stimulate and put the brakes on, accelerate and put the brakes on, grow the follicle to a nice size anywhere between 17 to 22 millimeters. We trigger, we don't wait for natural trigger, natural LH surge. And then in 36 to 40 hours, in IVF, we go in at 36 hours. In IUI, we tend to go in about 40, 42 hours. No one has said that one point in time is better than the other. And we gently use a small tube, which is done in the clinic, to use a cylinder tube into the womb and release the sperms. And then you also have the couple try naturally as well, and not just IUI. Now, I am a strong believer of supporting, even in IUI cycles, the luteal phase. I do give progesterone as well. Maybe not as much as in the IVF cycle, because I feel that when you trigger the ovulation, you are disrupting nature a little bit. So you want to help nature along to conceive. Now, the number of cycles, if in someone who is beyond 35, and I do 3 well-conducted IUI cycles, I feel that the time is right to seriously think about not going on and on and on, but seriously start discussing whether we should do IVF. In some instances where a couple has clear indications for IVF, but they just want to try, they ask you, Doc, can you just give me a chance at something more natural? I just want to see whether it can happen. If it doesn't happen, then yes, by all means. But if the sperm counts are extremely low, I will discourage them from doing that, because even that, the letdown of that is so psychologically tremendous impact it can make that sometimes you feel so hopeless, you just want to give up, you know.
Yes.
So I want to give them hope. I think, okay, if it's a reasonable thing to do, the sperm counts are not so bad, and maybe your egg counts are not so low, okay, reasonable to. Otherwise, I would waste no time to do IVF for the reasons I mentioned earlier. So in a very young couple, maybe I'd go 6 cycles.
6, wow, okay.
6 cycles, 4 to 6 cycles in a very young couple.
Yep.
But honestly, by the time I reach the 3rd and 4th cycle, the anxiety levels are so great that, you know, honestly, we would tend to seriously think about IVF by that time, you see.
Yes.
So in reality, by the 4th cycle, when things don't begin to happen, couples are saying, why don't I just do IVF and get a higher success rate and all that? But if you were to ask a fertility doctor, what will give the couple the highest chance of hopefully a normal, singular, healthy baby, it would be IVF, because these days we only put back 1 embryo. Okay, in IUI, sometimes inadvertently one follicle, one egg might sneak through, and you have maybe twins or even triplets, and even twins you can have preterm labor.
Yes.
And therefore, we would say in building your family, IVF gives you the potential to preserve your ability to conceive for many years ahead, for the reasons I told you.
Yes.
Freezing technology of the embryo has made a tremendous impact on how we help couples have babies.
Yeah. Very interesting. So let's say for a couple who have gone through IVF a few times and have failed, how would you suggest for them to continue? Or basically, I mean, it leads on to our next question. Would you suggest for them to use donor eggs?
Yes. It's got to do with their age as well, the quality of the embryos they have been getting. If it's not as good quality, very few eggs, she's already in her 40s and it's been a struggle. Yes, I think therein lies a scenario where we would seriously talk about egg donor. But one has to understand the psychology of it all. To be told that you have to use another person's egg and it's not genetically yours.
Correct.
It's a really hard thing to come to terms with. And sometimes you have to be able to suss out what is her or the couple's threshold. Sometimes the wife is ready to do so, but the husband is not, you know.
Yes.
He said, honey, I married you to have children with you, not the egg donor.
Yes.
And so I am not ready. And sometimes because the husband is unable to accept it, they may not even consider that option.
Yes.
But over time, then, you know, it's a decision that you don't make just wake up one
Not
day and
likely,
make,
for sure.
because it is a arduous journey. So what is a couple's threshold to say, call it quits? It is got to do with how I counsel them. If I say to them, Mrs. So-and-so and Miss So-and-so, or you know, I think we've come this far.
Yes.
You might want to, she might ask a question, or he might ask a question, Doc, do you think I've done everything I possibly can? I mean, one cannot answer that in the affirmative in all aspects. I can say, well, to the best of my knowledge, and you can please avail yourself to the knowledge of other doctors as well.
Yes.
I think, my dear, you have done your level best. It's time to think about egg donor or sperm donor, or in some instances, we discover that because they have not been working out, because they have a genetic abnormality, and that's the thing that's preventing pregnancy, and therefore you have to change your genetic material.
Yes.
And therefore, another reason why we go on to what we call third-party reproduction.
Yes.
The same analogy, or rather argument, for surrogacy. Although surrogacy is not allowed in Singapore,
Yes.
I cannot in good conscience continue to tell my couples, go ahead, your uterus is in this state, I tried to do surgery, it doesn't work out, but never mind, just keep on going, because I cannot talk to you about surrogacy.
Yeah.
That's, on my part as a doctor, the wrong thing to do. I feel that it is not allowed in our jurisdiction. There are reasons why we don't allow it. There are jurisdictions that allow it, and if you have repeatedly failed and you have all these precious embryos, I'm not willing to have it sacrificed again, then of course, there's such a thing as surrogacy. They may not even understand or know about this. There's such a thing as a surrogacy.
Yes.
You might have to look into this, think carefully about this. There are a lot of repercussions. I will give them opportunity to gain information on this, because at the end of the day, my duty of care is to my couple. They want to be a mom and dad. They've come to see me to be a mom and dad, not to go through tests after tests, prodded and probed and done all of this. I want to make them a mom and dad, and that's what I intend to do.
Very nice. In terms of donor eggs in Singapore, because it's definitely a topic that's not really talked about, and we've had a lot of ladies who come to us to ask, where can I get donor eggs? I mean, is this something that you could share?
Yes. First of all, gamete donor, that means sperm and egg donation cycles are allowed in Singapore. The government is very supportive of that, because they don't want couples to try and fail and utilize so much cost, and it's also cost burden to the country as well.
Yeah.
So the philosophy is, if you have a sister or a brother, it's within the family, your same genetic lineage, it is always preferred that you have those individuals help you to provide the sperms or the eggs.
Yeah.
And there's a limitation of age, 36 and beyond. We would discourage you from using your sister. Although if there's siblings, we have special permission, we can consider that, but your success rates will be poorer. So a good donor age, egg donor, would be 28, maybe 26, 27 to about 32. I say this is because I really don't think very young donors are mature enough to participate in this arrangement. And if an egg donor is married, you need the consent of the husband as well. You need the consent of your spouse before you do that. So that's allowed. But one of the challenges that we find is, unlike in other countries where there are egg banks, it is fairly difficult. The couple has to bring the egg donor to, or sperm donors we can import from the United States. Actually, we have certain centers where banks that we have been doing that for decades now. The only thing we have told the bank is, once you give us a sperm sample, you can't have it used for other families within the country, and so on and so forth, for obvious reasons. Now, for the egg donor, it is quite challenging, unfortunately. I wish it were a little bit smoother, but our government is very, very careful not to have an unbridled sort of commercialized sort of scenario as it is in other countries, which actually impacts on the couple quite significantly. If we have the couple has to bring the donor to us. This is one country where we expect the couple to have a known donor when it comes to egg donation, and it must be altruistic. You can only pay for the time away from work, maybe all the costs involved in for her to donate the eggs, the medications, etc. But you can't pay more than that. It must be very transparent, you see. So I mean, we have arrangements through some of the centers where we are able to bring in import eggs frozen eggs from elsewhere, but it goes through a very, very, very rigorous selection process, counseling process, Kim, because our government is very fastidious about this, because once you make a mistake in that area, the repercussions are so profound that it's irreversible. You see, so yes, it is difficult for a reason. Okay?
Understand. Okay. A lot of these questions you've actually answered, so there's probably only about 2 more questions that we could cover. Human growth hormone injections like Sison, what would they be recommended for?
I think in instances where the qualitative nature of the egg is of a concern,
yes,
particularly in the older girls and in situations where we have low egg counts and for some reason the eggs are just not doing what they're supposed to do. They're not fertilizing, they're not growing the way they ought to grow. I then tend to use the growth hormone because it works in the ovarian level, it works at the egg level, because in the pathway of the physiology of the egg, the intra-egg, inside the egg physiology, growth hormone plays a significant role in the physiology. They also play a significant role in the fertilizing ability of the egg. Now, what I'm saying is shrouded with controversy. Some doctors don't believe in this at all.
Yes.
I do believe it does make some impact. And honestly, if I'm going to, before I resort or resign myself and with my couple to the egg donor option, I want to be able to tell myself, have I done, without causing any hurt and harm, of course there's some cost to it, have I done everything I can, fairly conceivable, but at the same time, I'm not saying I'm going to use all kinds of esoteric medications and wasting the resources and the time of couples. These are reasonable things that some portion of the IVF community believes in. Then I will put it to them. I will then have them do their own research, and I will tell them I would like to use this for you. And there are different ways in which I use it. By virtue of the fact that it's a growth hormone, enhanced growth, I tend to use a low dose over a period of time rather than high doses within the cycle. But this is just a matter of preference. And as we give a couple DHEA and growth hormone and tweak the stimulation protocol, then using either dual stimulation or not, we try to get a multi-pronged approach and see whether we can converge towards getting a good embryo. Of course, we can't do the pre-implantation genetic testing, but sometimes, you know, if you have just the one embryo or maximum 2, you might not, even if it's available, you might not want to venture to put it in and do the PGT, and then you just take a calculated chance and do it. And if God willing, you have an embryo that grows and becomes a little sweetie pie, that'll be so great. But if not, then we can tell ourselves we gave it our best shot, we gave it our best try, let's move on to the next phase.
Yeah, that totally makes sense. Okay, so last question. How does your clinic differ from public hospitals? I think we've answered this, but in terms of live rates from your clinic for women 35 years and over, would you have an approximate figure?
I would like to just show you the figures of 2 IVF centers that I work with. They will give you, this is one of the centers. Can we have it up on the screen? Is it possible?
Go ahead.
I just want to show it to you. This is slide number 22 and 23. In this IVF center, the success rates of a clinical pregnancy between the 35 to 39 age group is about 54% and a live birth rate of 48%. These are the things that you should look for in an IVF center.
Okay.
And of course, it drops significantly at age 40 to 45 to 26%. And this is reasonably good. In some of the centers, you can't even get 5%.
Wow, okay.
In the other center that I use, you have respectively 67% and 27% for this age group.
Okay.
I might add that I use these centers because of their high pregnancy rates. The embryologists in these two centers immerse themselves in the looking after of their patients. They counsel the patients themselves. I'm not at liberty to say names and centers.
Okay.
It's not appropriate for me. But the whole ethos of most of the centers in Singapore is that we do our utmost. Okay, we give it all we got because that's what we are all here for. And when we don't get a success, we anguish with our patients, but then we dust our knees, we pick ourselves up and venture again.
Yes.
Okay? So that I dare say is the philosophy of all of my colleagues who are in this field. We give it our all, you know.
Fantastic.
So to answer your question, what is the difference between a private practitioner maybe and a public practitioner? The public practitioner, the tremendous advantage of the public hospitals is one economic thing is you have the special support from the government. Our government is actually, compared to most other governments around the world, has done a huge amount of support compared to even around the region. So we are thankful for that. In the private sector, we don't get a chance to enjoy that, but nevertheless, I dare say we are a little bit more nimble in changing protocols. We can try to be maybe more individualized in our treatments. We are very personalized. We are there ourselves. But this is not to say that you cannot get personalized care in the university department or SGH or KKH. You can. As a private patient, you can. And also, sometimes, you get a nice, seamless process going on in the government sector where the scans are done very expeditiously, the injections are given, the nurses are excellent, everything goes as a nice flow. In a continuum, you see. But in the private sector, one advantage we have is we may gain faster access to some of the newer drugs, but that doesn't mean newer is better. But sometimes we have tried everything we have, and we want to give it another sort of new breeze, as it were, into the stimulation, and we do get the newer drugs a little bit faster than the government hospitals. But I think we're a tightly knit fraternity. All of us know each other. We've already come to realize each other's nuances. And sometimes when I get asked about another style of management that I'm not comfortable with, I would say, let me arrange this for you with my colleague. We are all friends. We are here to make moms and dads of our couples.
Very nice. I think it's been a super informative talk. Thank you so much, Dr. Nair, for joining us today.
Welcome.
I'm sure so many ladies have found it so useful. So,
I hope so. I hope so. And I pray for all of us who are trying to be mummies and daddies that you will have so many children with pitter-patter of little feet all around your house. Okay?
Thank you so much. Okay, so thank you everybody for joining as well. And thank you, Dr. Nair, once again.
Thank you, Kim, for taking all this effort to help our couples.
No problem. Thank you.
Okay. Take care.
Thanks.
Bye-bye.
Bye.
Bye.